So I'm a diagnostic radiologist, and Baris Turkbey, who's speaking after the break, has done some fantastic work on MR and prostate cancer, and I think that's going to be something that will give a lot of background on and show you the cutting edge stuff happening there. What I thought I would do then for this presentation was maybe focus on active surveillance, and so we're now looking at low risk disease. So I'm going to maybe give some background here, show some of the imaging findings in prostate cancer in general, and then at the end show you some of our early results in prospective trials in using MR for targeted biopsy and active surveillance. So what is active surveillance? This is different than watchful waiting. In active surveillance, we're actively monitoring the disease with the expectation to intervene with the intent to cure only if essential. So there's this concept of not only closely monitoring, but of intervention, but delayed intervention, only when it's necessary. And this has now become part of the cancer care guidelines. So the NCCN now recommends active surveillance, and this is a relatively recent change over the last few years for patients with clinically insignificant disease. So this whole idea of prostate cancer being overtreated as a real clinical problem is well known, and this is one of the current solutions in the guidelines to address this, is to start to bring in active surveillance. It's really based on the belief that if appropriate triggers for the intervention are identified, then the patient will still have a favorable outcome. And this is somewhat of a belief. It's based on some prospective trials, and I'll briefly talk about those. But we really have to ask ourselves the question for each individual patient as people involved in patient care: how sure are we that the given patient has insignificant disease? Can we really do that today? How sure are we that we can intervene before the disease spreads? So there have been definitions then put out there based on the current assessment methods for clinically insignificant disease. And we have to do this without radical prostatectomy data, obviously, without the full pathology of what's going on in the prostate. So we have the Epstein criteria and the D'Amico criteria, and these are based on the number of cores positive or the nature of cores on biopsy, the PSA level, and PSA density in the case of Epstein criteria. So these are important things to be aware of when assessing imaging modalities and different approaches to cancer assessment. Is, do these add value to the current definitions, clinical definitions of clinically insignificant disease? I think we still have a moving target somewhat in the definition pathologically of what's clinically insignificant, and this is slowly crept from Gleason 6 to now Gleason 7 disease. And Gleason 7 disease, even, there's some subtlety in whether we're talking about Gleason score 3+4 versus 4+3. So we have seen a creep in the Gleason score threshold. I think the lowest threshold that is currently thought of is Gleason 6, but at a larger volume than previously thought. So a few years ago, people would say that significant disease, if it's Gleason score 6, greater than half a cc in volume, and now it's sort of up to 1.3, 1.4 cc's. And many investigators now, looking at the new way of scoring Gleason 4 that's been put forward and now in clinical use, are saying that it really should just be Gleason 7 and higher, and forget about 6, whatever the volume. So we're seeing this, and this is very important, very, very important when we're looking at evaluating imaging tests for prognostication. We need to know what it is in terms of pathology that is going to be the threshold. If we don't have this information nailed down, we have to wait 15, 20 years for the results of outcome studies to figure out prognosis. So in prostate cancer, we face this dilemma in low and intermediate risk disease, where to really assess clinical value, the outcome times that we have to wait are very long. So this pathologic definition is very important. So let's say that we're talking at least high volume Gleason 6, if not Gleason 7 is our threshold. So if we look at 3 of the major prospective trials in active surveillance, so we have the one in Toronto, and this is the work at Sunnybrook, Laurie Klotz and his group, the Prius trial in Europe and Hopkins, they're all using PSAs less than 10, PSA densities less than 0.2, and cores less than 2 cores, Gleason score 6 for most of the studies, with relatively low volume disease. But you can see how even in their entrance criteria, they're somewhat variable, with the Toronto group letting more higher grade, higher volume patients into their active surveillance cohort. They also have slight differences in their approach to defining the trigger point for now doing biopsy. So when do you re-biopsy the patient while you're watching them closely? So in Toronto, they re-biopsy routinely, not on entrance, but at 6 to 12 months, do it again at 2 to 3 years, and then if the PSA doubling time is less than 2 years, they will do a repeat biopsy, and they're now actually doing MRs as part of that. PSAs are done every 3 months in the first 2 years, and then every 6 months. And you see other variations as well for the American and European trials, again with a little more aggressive approaches to re-biopsy and surveillance in the other groups. All right, so that's sort of a little background. What are the outcomes? What's happening with these patients? Well, the survival so far is very, very good. So medium follow-ups, we're looking at 80 months, the longest in Toronto, 47 months in Europe. So we have very, very good survival results, but prostate cancer isn't all about survival. It's also about living with the disease. And so when you look at patients, 30% of patients at 5 years will require treatment. So of those on active surveillance, 70% at 5 years are doing fine, but 30% actually have evidence of disease that requires treatment. So it's broken out of that low-risk sort of paradigm. Also, sometimes the patients, and many times the patients say, I don't want to deal with this cancer anymore, do something for me. So we have this issue of a significant number of patients, even at the 5-year point, requiring intervention. But what's important is, of those 30%, half of them have disease that fails that treatment, okay? So these patients are ending up, a significant number of patients, and we're talking huge populations, right, that are in this low-risk category. This comprises a huge proportion of men. Half of those patients, so 15% of the overall cohort, are failing that treatment. So this is a big deal. What's going on? Why are these patients failing? Is this because we're not intervening early enough, that in fact active surveillance has failed at 15%? Or is it that they shouldn't have been on active surveillance in the first place? So is it an entrance problem, or are they failing during treatment because PSA is a lousy test for the trigger point, or is it both? And so we need information. We need to know what's going on in these patients. So what are the pros and cons? Reduce morbidity and improve quality of life, reducing healthcare burden. We have significant issues with patient anxiety, knowing that they have cancer, progression and mortality. And in fact, patients in this scenario, because of anxiety, do actually experience erectile dysfunction, either related to that, or in fact, it's been shown related to the number of biopsies being done. So it's not like the active surveillance itself is innocuous in terms of some of the quality of life measures. On this uptake issue, we see some differences in US and in Europe and Canada. So in Canada, I think we're more in the 30% range for patients willing to tolerate active surveillance, while in the US, it's down around 10 to 15%. So it's a bit of a cultural thing, a healthcare system thing, but certainly the majority of men in the world who are eligible for active surveillance don't choose that as their treatment choice. And why is that? They don't have the confidence. They don't know for them if they're going to be one of those 15% of patients that is going to completely fail this approach. And particularly young men, this is a problem. So if we're going to distill this down to unmet needs, they're basically, we need better patient selection, we need a test with a very high negative predictive value for clinically significant cancer, and we need better identification of disease progression. So a better idea to identify when progression occurs and confirm this with a biopsy, which means we need to know where the disease is. So where, when, high negative predictive value. And so here comes imaging. Imaging has this ability to map where the tumor is. It has, and certainly a lot of data on MR. The retrospective studies are now coming out. This is one from looking at low-risk patients from UCSF, essentially showing that compared to PSA, that MR had a hazard ratio of 4. So if an MR showed something in an active surveillance patient, their risk or their chance of being intervened upon, needing intervention or having intervention was 4 times higher with an MR finding than it was with the PSA doubling time finding. So certainly evidence that MR is on the right track. And there's now some further prospective data coming out essentially backing these numbers up. What about now getting into how we're going to do the imaging? So one of the first questions is, we're talking large patient populations, do we need the endorectal coil? I would say that certainly with 3T scanners, we are not using the endorectal coil at all. I would say with some of the very current 1.5T scanners, which have SNR performance improvements compared to the stuff 5 years ago, that you can actually do these quite well, and just back from Vancouver, doing these without an endorectal coil. So I think where you want to keep costs down, efficiency up, because we're talking about larger populations, we can do this without the endorectal coil. The key imaging approach that has opened up, I think, MR to the radiology community and to us is diffusion-weighted imaging. This is available on just about every scanner. This is a key part of neuroimaging, and getting B values close to 800 to 1,000 is critical, and getting stable diffusion coefficient measurements is important, which means we want to have do the fits for diffusion coefficient between 100 and 1,000, eliminating the very low B values, which cause a lot of drift in the ADC calculation. So this is important in getting ADC. And this is a raw, I know the lights are really bright here, but in terms of looking at the raw diffusion-weighted image without the endorectal coil, you look for these bright spots, very easy to see. The bonus with diffusion-weighted imaging is that, like spectroscopy, but at much less overhead in terms of performance, we're able to see a correlation between Gleason score at the bottom here and just get the other pointer. Gleason score at the bottom here and ADC value. And this is critical in that I told you we have to identify the Gleason score over 7 component. Here's an ROC curve showing that when we pick a threshold of 1,000, that in fact we get very good region under the ROC curve here, or area under the ROC curve for segregating disease that needs treatment from disease that doesn't need treatment. And I can tell you this works in clinical use. I've been doing it for a couple of years now, and it works well. DCE MRI is useful, I think, as an adjunctive test. We still do it, and for this we need high temporal resolution imaging. Like breast cancer, they enhance early the tumors, and they wash out quicker than normal tissue. So this curve has varying sort of degrees of amplitude. This is normal tissue, can have washout, flat or high, but certainly the tumors themselves have much higher early enhancement, much more rapid washout. And this is actually helpful in I'll show you a case of that. I think another key thing to recognize if you're doing research work in this area is that prostate cancer is multifocal. So 80% of cases, prostate cancer is multifocal. And what is a big change in the uro-oncology community is the recognition that, in fact, it is the dominant focus of these multifocal disease sites that in fact drives the prognosis. This was highly controversial, and I think more recently has become more accepted. And this is why we're hearing about focal therapy. But this is actually critical to biopsy strategies too. You don't have to biopsy every cancer and find every cancer in the prostate. You're looking for the largest tumor, and it's about 4 times larger than the second biggest tumor. So there almost always is a dominant lesion. And this is a key aspect to work in this area, analysis of specimens in this area as well. So not all cancers need to be found, and we already talked about Gleason's score. This work has now, all of this field in MR has now progressed on to consensus recommendations. So we're quite well into this field, this field and its clinical translation into the wider community, urology community. So this is European Urology 2011, follow-up article in European Radiology 2012. For those people who actually are involved with their radiology departments, I'll quickly show you how an interpretation is done of these. For those people involved in patient care, essentially what we're doing in radiology departments now is we are advocating the use of standard diagrams that go into much more detail of location so we can get this information to our radiation oncologists and urologists often who are doing the biopsies as to where these tumors are. And these are consensus documents that are being put together. So here's what a cancer will look like. So here we have a T2 weighted image. Is that the cancer? Is this the cancer? Is there cancer over here? You look at the ADC map. We use a very specific window level setting, and there's clearly a cancer here, matches the contrast enhanced. So in fact, this is the site of disease, very small. This patient was biopsy negative, and that had a Gleason 7 focus that we were able to hit with biopsy, cognitive registered biopsy. Lesion here, easily seen, but a second lesion identified with perfusion imaging. Go back, there's a little wedge here, so I would call 2 foci of cancer, one here and one here. In fact, multifocal disease, but this was the highest grade focus, the dominant lesion, the one that's important in terms of driving the patient's outcome and decision making. So as long as we hit this one on biopsy, we're okay. What's the MR performance as of today? It's dependent on size and grade. So this is very important as well, is that our sensitivity drops as we get to smaller tumors, Gleason 7 tumors. And this is not necessarily a spatial resolution dependent thing. This is related also to the histologic nature of these tumors. So getting higher resolution isn't necessarily going to solve this problem, but still very good performance for what we would consider significant disease thresholds. Gleason 6, not so well. Also, we need to know about the location of these tumors, and this is very important for interpretation. So we know that most cancers sit in the peripheral zone posteriorly. Our biopsy strategies are aimed posteriorly, which means that the patients that come onto active surveillance and are thought to be low risk, who are actually high risk, and that may be failing in the first few years, are the ones with tumors hiding in the front of the prostate, exactly where you'd expect. And so these are the active surveillance scenarios where misidentification of low risk is occurring. The problem is that when you start to look at the results of diffusion-weighted imaging in the anterior prostate and transition zone, it doesn't work so well. And so we need help in this area. This is an important area for research, actually, is in trying to identify or categorize tumors in the transition zone. And this is work done at the University of Chicago by Dr. Odo and his group, showing in fact that cancer and stromal hyperplasia have a big overlap in diffusion coefficient measurements. This case was a cancer, but many other cases like this are not cancers. And so this is an interpretive problem we face. We're saved by the fact that texture, in fact, helps us. So, in fact, these are 2 patients deemed low risk, and sorry, these are not low-risk patients, but these are patients actually with high PSAs but repeat negative biopsies. But these are exactly the scenarios we'll see in active surveillance as well, with very large anterior tumors, and it's this textural change in the prostate that's very easy to identify. Here's another case of one of these anterior tumors that it's identified very, very well. And this patient had, on a targeted biopsy, was low risk before, targeted biopsy 3+4, 70% of core positive. This is a patient who was on active surveillance for a long period of time, but actually ended up with a rise in PSA, had this obvious focus of cancer here. This one on both, as you'd expect, both the random biopsy and the targeted MR-targeted biopsy had Gleason 9 disease. But the random biopsy was 12 cores, the targeted biopsy was 2 cores, same result. So in patients with posterior tumors on active surveillance, the advantage of MR is, yes, identifying the disease, but a significant reduction in the number of cores required to make the decision-making for treatment. In patients with anterior tumors, so this, as in this case, the advantage here is in identifying, this is just shows how I do the layout and interpretation. I'll skip that for the sake of time, but this patient, in fact, has a very anterior apical tumor here. Again, the T2 and diffusion show this the best. In cases like this, the random biopsy will show low-risk disease again and will not hit this. This area is actually quite painful to biopsy. It goes right through the apex of the prostate and urethra, and most of the time this area is never really sampled. So in this case, we did directed biopsies here, and we found, in fact, 3+4 disease filling most of the cores here in the anterior apex, but the non-targeted core results showed low-risk disease. So again, the geography, identifying actionable disease, we're seeing that MR can really help with this. Well, how do we biopsy? So if we look at this case, this is a patient entering onto active surveillance. And we see this tiny, and this is what starts to happen in low-risk disease. In low-risk disease, the MR is often normal, and much of the research work done in prostate cancer is done with whole mount correlation. The problem with diagnostic evaluation and whole mount correlation is all these patients have cancers that have warranted a radical prostatectomy. I know as a radiologist, every case I'm looking at has a cancer in it. In active surveillance, yeah, I know they have a cancer, but many of these cancers are going to be incredibly small, in fact, not detectable. And I'm faced with that scenario of one of the toughest things in radiology, they say when you're training, is it normal or is it abnormal? If on an exam you show a radiology resident a normal chest x-ray, he'll have a heart attack. He won't be able to figure out it's normal. He'll assume that there's something abnormal. So the first trick is identifying, is there a tumor there? And in fact, there is a tiny little tumor here, right at the margin. Okay, you can see it here on one of the perfusion scans as well. So tiny little tumor. How are we going to hit that? So here we're using something, so here's just a zoom up showing that tumor right at the margin. And I will tell you, we use the Artemis system, which is a nice piece of technology that came out of some work done here in London in Dr. Fenster's lab. But there's always hiccups in this, and Dr. Fenster would even admit that this kind of tolerance at this angle of attack is probably less than 2 millimeters. How are we going to be sure we hit this thing? And so the process here involves contouring, 3D ultrasound to MR fusion. So we contour, we identify, and we stick needles in here. I will tell you, 2 of these 3 cores had periprostatic fat in them. We did get 1 sample of these cores through here showing Gleason 6 disease, 40% of the core. So this is still a low-risk patient, even though they had MR-identified disease. But here we're quite confident that we did sample the area or an area of concern on MR, and the rest of the prostate looks normal, hopefully adding confidence to the low-risk stratification of this patient. This is another system that we use. This is Dr. Malo, who does the biopsies at our center. This is a freehand system that uses another type of fusion method that's less restrictive, perhaps a little less accurate than the Artemis system. This is the patient with this tracker sort of hardware here. The advantage of this, though, is he gets to use his brain. I'm going to put right his forebrain over there. He gets to use his brain for cognitive registration in a much more rapid fashion. I will tell you, he can hit a target now within about 3 minutes. Very, very fast biopsy approach. So he can do a 3-target biopsy in about 10 minutes now, and the random takes another 5. So highly efficient process because he's not being restricted by the hardware as much. Disadvantage is perhaps a little less accurate in terms of you know, all the robotic co-registration. This is more freehand, more deformation. This is an MR ultrasound fused panel, and this is the raw ultrasound image. So he uses both of these overlays to cognitively co-register and confirm as well. So what are our results? And I'll finish on this slide, and happy to answer questions about this study. So what we did is we have 2 studies underway. This one is a CINO-sponsored trial that was a cross-sectional trial, prospective trial in active surveillance. And here, all patients formally on active surveillance, either on entrance or who have our biopsy for cause. So their PSA is going up or they hit a 3-year time point, are eligible. We're actually up to about 65 patients now. These results have held up for 65 patients. So the mean number of cores being done, so all the patients get a random biopsy, and if they have a target, they get a targeted biopsy. The reference standard here is prediction of the 12-core biopsy result, okay? And Gleason upgrading. So these are the 2 endpoints. So how often did we Gleason upgrade from baseline, and how often did we predict at least the highest score on the 12? So what we found is that, in fact, with a median of 2 cores per patient, even with 10 cores reduced, 20% of the patients still had actionable tumors missed on the 12 core. So in 1 in 5 patients with as little as 2 cores, we're picking up disease that was missed on the 12 core. So far, and I'm a little embarrassed, this number should probably be about 10 to 15%, not 0. We have not yet missed a Gleason score 7 tumor on the 12 core that was picked up on the 12 core, and we have not missed a Gleason score 6 greater than 50% of a core. I think this number will go up based on some other studies that we have ongoing to probably about 10%, maybe 15%. But I think this number is going to stay low. In other trials so far, this is sitting around 5%. So this is very compelling data. If I was going to go on active surveillance based on this, there's no doubt in my mind that I would want an MR done before I made that decision. Thank you very much for your attention. So, so the question was, you know, what's the deal with the endorectal coil? Do we need it? Do we not need it? What's changed? And what I would say is the following. First, that there's no question that when you do use the endorectal coil, that you really can see much smaller lesions, in my mind, with higher confidence. So it's not that you necessarily can't see the lesions at 3T without the endorectal, but my confidence level in certain regions of the prostate goes up. It's very hard to show this in studies without very large cohorts, but that detail is there that gives you the confidence. In the assessment of extraprostatic disease, so if a surgeon sends me a case or a radiation oncologist sends me a case where they want to make a decision to do a radical P or not, and if I say there's tumor outside the gland, that they will change their decision for that patient. I like to use the endorectal coil because I'm looking for findings in the order of 2 millimeters or less, and this is going to impact management. So, so I would say right now, the recognition of the fact that really we only need to pick up 2 millimeter type findings or 3 millimeter type findings in the preoperative staging scenario is one reason that I've moved away from the endorectal, because most of the cases we're getting are not that. The second is that most Gleason 7 cancers are bigger than a few millimeters in size. So in fact, there's a high correlation between Gleason score and size. And so many uro-oncologists do not want me to tell them the location of a whole bunch of really tiny tumors that no one can biopsy, no one can hit. They really want to know the location of that significant tumor. So we don't want to get into the same over-detection game. And with 3T non-endorectal, I've gained a lot of confidence looking at these low-risk patients that we can do this without an endorectal coil. And these results have now been duplicated at other centers as well. And so as a practicing radiologist, I would say that there's a lot of evidence and personal experience now that says this can be done. At 1.5 Tesla, on the sort of systems that are not just brand new, that don't have these new coil receiver chains in them that are SNR optimized, I would say I think we're really sacrificing something there as of today.
So you think that there is any role in the initial screening of a patient with prostate cancer for MRI without biopsy, just looking for a significant sized tumor and waiting for a certain tumor to reach a level of volume before undergoing biopsy? Or
So I think this is a very, very important question. There's a number of groups who are now have secured funding in a couple of countries to actually do a study where you repeatedly do MRs on low-risk patients in an active surveillance setting. So not just on entrance or cross-sectional study like this, but they'll actually image them prospectively at baseline, again at 1 year, again at 3 years, to see if MR can do a better job of catching that transformation from low-risk to high-risk disease. There's some very preliminary data suggesting that this can happen in about a 3-year time frame. So patients who have negative MRs, negative biopsies, or low-risk biopsies, that, you know, when you look at these small series that have been done, it's still anecdotal, almost abstract type data, that you will see, you know, they have cases where patients transform into Gleason 7 MR visible tumors around the 3-year time point. So it suggests that there is a real potential role for MR here. So yes, the short answer is yes. I think it's a very promising area for work. The data is not really mature yet. Yes?
Very good, very, very nice presentation. Thank you. During your presentation, the interpretation of MRI, you emphasized, rightly so, that the need to avoid false negative. To find a patient that needs to go on active treatment, also reassure all the patients that an active surveillance and want to be sure that they are not getting in trouble very soon because of their disease. But you didn't specify something that we have found in our experience here that is being quite a problem. So the presence of false positive. So benign pathology, even in the periphery, that to me mimics a tumor, and we find in a significant number of cases that we address the biopsy there, and we find maybe prostatitis or granulomas or even nothing, and we don't know why.
Sure.
Because when you have all the findings, T2, hypointensity, diffusion, ADC map, TCE, if everything fits, it's easy. But most of the times, it's not the case.
Sure.
And then sometimes we struggle to decide. And in a significant, not huge number, in a significant number of cases, we have false positive.
Right. So this is where I think when we look specifically at low and intermediate risk patients, we need to have MR data focused on those populations. Because remember, when this publication sort of started in prostate cancer MR imaging, it was all radical prostatectomy cases, as I mentioned. So first T2 weighted imaging was perfect, 90% accuracy. Then T2 in spectroscopy was perfect, big results from single center trials. Then T2 in dynamic contrast enhanced imaging was great. And I can tell you my experience with all of those in low-risk patients was exactly what you've described, is that lots of false positives, because, and presumably there's a reason for that. Their PSAs goes up, that's what's triggered their attention to their family doctor or urologist. So there's something going on in the prostate. And so we see these false positives. But the good news is that I think when we've started to look now with current imaging with diffusion, that the positive predictive values published for imaging findings are at least 50%. In our hands in Toronto, they're sitting about 70% to 80%. So this is in comparison to, remember, these patients have been triggered and have had a positive low-grade result, low-risk result already. So we start to reframe the question. Reframe the question in the sense not are we detected cancer or not, but are we detecting significant cancer? So this is the first change in approach. Are we detecting significant cancer? And are we getting incremental yields above the random biopsy approach? So as long as I'm not so to summarize, as long as I'm not overcalling to a point where I'm doing almost the same number of biopsies that I would with a random biopsy, and I'm not overcalling to a point where I'm hurting the patient, and number two, doing it, I can sample with far fewer cores and actually incrementally get Gleason upgrading. If I can accomplish those two things, I'm doing something useful. And the data I showed at the end of the presentation, Dr. Turkbay may speak about this as well. They're getting similar results. The group in Holland is getting similar results. Is that what MR is doing, despite this slight overcall issue, is we're so much better than not doing MR that it's having, we think, real impact.
In your experience with active surveillance, have you ever seen the cases when the tumor goes away by itself? So can the immune system really fight cancer?
So no. I wish I had, but I haven't. What I have seen, though, is some of these false positive findings go away. So we have had scenarios, and it's interesting. There is a whole bunch of stuff going on in the imaging that we don't understand that is producing signal abnormalities. And so I have seen patients with high PSA, young patients in their 50s, late 40s. They get a biopsy done, it shows PIN, it shows very abnormal MR, particularly the perfusion MR. They go and start eating lycopene and tomatoes and doing whatever else they do, and they come back, and the MR looks completely different. It really almost looks normalized. Their biopsy actually comes back in the same area showing normal prostate. Now, I don't know if it's a sampling problem, but there's no question that the prostate itself on the imaging is dynamic in terms of perhaps these other issues, cancer precursor, inflammation, and this is a very potentially interesting area, and an area that has been studied, the role of prostatic inflammation, the role of the prostatic stroma, the role of diet and other factors in the instigation of prostate cancer or setting up the environment for prostate cancer. So your question might be very relevant in the evolution of prostate cancer. Can we slow the evolution? Can we not necessarily make it regress, but stop it from happening at an early age?
Thanks for the presentation. Just a two-pronged question. Firstly, do you see that MR spectroscopy is now obsolete, or is there going to be a role for it at all with diffusion being such a good tool? And secondly, how do you optimize your DWI to avoid susceptibility at 3T?
So I'll tell you a quick anecdote. I asked this, I was at the ISMRM meeting, so a big MR meeting populated mostly by physicists, but also by a lot of radiologists, and I asked this question. So are we done with spectroscopy and other modalities in cancer, and should we focus our development on diffusion? I think I was almost lynched. So the short answer is no. I think spectroscopy is a really powerful tool. And I think that what we need is better ways of applying this clinically in robust fashions for it to be successful. So I think for those scientists and researchers who have methodologies of doing spectroscopy that are robust, can be done with without a lot of technical overhead, so to speak, on the clinical side, there's potentially a great role for it. I think the whole area of hyperpolarization also, and the use of various pharmaceuticals is something that is of tremendous interest right now, and it's not sort of standard spectroscopy, requires pulse sequence modifications, whatever, but would drive perhaps the metabolic imaging side of MR, and so I think for those are a couple of reasons why it's very important. In terms of doing the diffusion-weighted imaging, the good news is that phantom sort of multi-center testing on various manufacturers has shown that with the current scanner technology from one of the manufacturers, the latest one, and from the other two, their legacy technology and their current ones, that the variation in ADC measurement is probably no more than 10% across manufacturers if you follow a consistent protocol. And so the use of ADC as a quantitative parameter is, I think, a very promising thing, but we need a SOP, a standard operating procedure, for how we do this. And this is why these consensus documents that I've shown you are so important for the translation of diffusion-weighted imaging and quality control in that, to answer your question, across sites. But I think the good news is that we have some stability in this measure, reasonable stability at the beginning, and perhaps we can look at refinement. So the way I do it now is I make sure I get away from this bi-exponential effect by keeping the b-values at least 100 or higher and doing at least 3 samples.
You see a role for the endorectal coil in the context of focal therapy, in terms of selecting patients appropriate for focal therapy and for planning it in terms of delineating intraprostatic lesions?
I think that, you know, where we are right, so that's a good question. I think focal therapy is very much in evolution. And so I can make a few broad statements. The first is, I think, where we sit today with focal therapy, we really need to be precise about the treatment. The cancers creep along the capsule, they're near the rectum, they're near the neurovascular bundles. How do we treat right out to the edge of the prostate without damaging adjacent tissue? For that, we need precision. How do we achieve precision? Well, it'd be good to get lots of signal near those margins. At the same time, when you inflate a balloon in the rectum, you're pushing the rectum right up against the prostate. And you may be making it harder to achieve your goal of sparing the rectal wall. Having said that, the jury's still out, I think, on what the best approach is. So I don't know the answer. I do think, to summarize, I would say that it is critical to see the cancer during the treatment. So this is where we're pushing to do diffusion-weighted imaging intra-treatment as a quick scan, so that all the deformation and everything else that's occurring between the diagnostic scan and the treatment becomes a non-issue, and we can actually treat as we directly see the tumor.
A lot of these patients are on drugs like 5-alpha reductase inhibitors, and with long-term use of 5-alpha reductase inhibitors, you see that the low-grade cancers kind of, decrease, and the high-grade are selectively overgrown. So does this pose any problems or challenges in diffusion-weighted MRIs?
Right. There's very limited data on the long-term effects of 5-alpha reductase inhibitors on imaging. There is some data showing that there is change in blood flow, or at least enhancement patterns in the periurethral tissues after administration of 5-alpha reductase inhibitors in normal periurethral tissue, so in the transition zone. I think our initial concern was that if you gave patient 5-alpha reductase inhibitors, would you actually mask cancer? I don't think that's been the case. I'm not aware of a formal study where someone's done this comparison, but we still see cancers quite well with patients on 5-alpha reductase inhibitors. If they're on true sort of hormonal therapy, like something that interferes more with or more castrate type therapy, then we do see lots of false positives and some false negatives with MR, so that really messes it up. But 5-alpha reductase may be okay. It's a very interesting question whether we can actually see the Gleason 7 subcomponents growing or see them better. And so does 5-alpha reductase actually improve our ability to identify those patients either who have Gleason 7 or higher disease by getting rid of the Gleason 6 component, or in fact allow us to see that component growing better by giving us better differential between the target that we want to see in the background. And I think that's a very interesting research question that we could look at.